Good morning, ladies and gentlemen. I think we're able to resume our hearing with Mr. Redfern. Am I correct, Mr. Duncan?
That's correct, my lord.
Right. Good morning, Mr. Redfern.
Aye.
As you're aware, you're about to be asked questions by Mr. Duncan. But before then, I understand you're prepared to take the oath.
Yes.
Just sitting where you are, could I ask you to raise your right hand and repeat these words after me? I swear by Almighty God
I swear by Almighty God
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you very much, Mr. Redfern. Now, I don't know how long your evidence will take, but I understand it may extend over the day and possibly even into tomorrow, but we'll just see how things develop. I would usually take a coffee break at about 11:30, so we will probably rise about then. But if at any stage in your evidence you want to take a break, just give me an indication and we'll break. I mean, feel that it's entirely a matter for you.
Okay, thank you.
Right. Mr. Duncan.
Thank you, my lord. Good morning, Mr. Redfern.
Aye.
I wonder if we could start maybe by just having you move your microphone just a wee bit closer.
Is that better?
I think so, yeah. Sometimes the acoustics in here are not terribly great. I wonder if we might just begin by having you give us your full name.
James MacDonald Redfern.
And could you tell us what your profession is?
I'm Director of Women and Children's within NHS Greater Glasgow and Clyde.
And were you previously the General Manager for Acute Hospital Paediatrics and
Yes,
Neonatology?
Yes.
And you describe your responsibilities in your witness statement, I think, as being the operational delivery of clinical services, is that right?
Yes.
Is that as General Manager or as Director or as both?
It's more operational as General Manager. The Director role is a more strategic outlook to it, and a wider scope. It's women and children's as opposed to just hospital paediatrics and neonatology.
Okay. Last week we had evidence from clinical and nursing staff, and the clinicians all said that they saw their duty as being about the provision of clinical care, and they saw management's job as being about the provision of a safe environment in which to conduct that care. Is that a distinction you would recognise?
Yes, but I would qualify that by saying that I work very closely with them in achieving that. So it's a very close working relationship between myself, colleagues who you would call managers within the service, and the clinicians that you're referring to.
Yeah. And I wonder if you could maybe just describe to us then what, how would you encapsulate your role if we just take General Manager to begin with?
So General Manager primarily has a number of functions. The first is that we have a safe clinical environment for which to work in. We have very strong relationships with the clinical teams that are working there. We are looking to try and make sure that there's a robust patient engagement and that the services function to the key priorities that the board and Scottish Government would expect from us. So that could be both scheduled care, unscheduled care, so from waiting times to emergency care.
Okay, thank you. Now, what I want to do is move forward and start to look at some of the events that the inquiry is interested in. Now, there are a number of issues I want to ask you about in relation to the period around the handover of the hospital and events in 2015 and after that. But I want to actually focus to begin with on slightly later events because there's quite a lot to go through on those. And I think we want to make progress on them as much as possible now. So I'm going to start with the events in March 2018 in relation to the matter that I think came to be known as the water incident. And I think you've got, I think, 2 or 3 paragraphs in your statement about that. So I would like to ask you just a little bit more about that matter. I don't think you'll need to look at your statement, but have you got it beside you?
I do. Sorry.
Yeah, thank you. Now, the 2 issues I particularly want to focus on are to do with communication. And one is communication with patients and families. And one is communication within the organisation to do with the concerns that were being discussed at that time. Now, let's take the second of those issues. So communication within the organisation. Now, in your statement at paragraph 71, what you say is that normal escalation processes were in place through the chair of the IMT, and the service via myself were in place ultimately to the chief operating officer, and so on. Now, can you explain to me what that means?
Okay, so the IMT has a responsibility to obviously the chair of the IMT is responsible to make sure the IMT functions properly. One of those functions is that at the end of it, there will be a formal minute of it, and that there will be a summary of events that have unfolded through the IMT up the organisation. So the chair has a responsibility to communicate that to ultimately who the board's director of infection control. So they would make that report of what the outcome of the IMT was.
Okay, there's a couple of things that arise from that. Let's take them in stages. I think we can see in the IMT minutes that there's, I think, always a section in the minutes, at least, that records a discussion around communication. Is that right?
Yes.
And would that section set out the agreed communication strategy at the IMT?
Yes. What there would normally be somebody from the comms department at the IMT. What they would do at the end of the IMT, as well as that. Sorry, I thought in the previous question you were asking about the formal escalation up the organisation. They would take and draft a statement for purposes of either release within the organisation or indeed if we had to report to outside stakeholders, and that would go through that process corporately, the director of comms and senior execs within the board.
Thank you. Now, I was asking also about the escalation question. As I say, in your statement, you talk about the normal escalation processes being in place and that those included going via yourself. So what does that mean?
So I would report the outcome of the IMT to my direct line manager at that time was Mr. Kevin Hill.
Thank you. Now, the evidence that we've had so far is that at the IMT of the 6th of March, at which you were not present, there was an expressed dissatisfaction about senior management response to previously expressed concerns about environmental risks from infection control. Is that something that you have a recollection of?
Well, I wasn't at the said IMT. I know there were challenges in terms of the whole infection control situation, but I can't remember directly anybody raising any specific concerns with myself.
Okay, I wonder if we could, Mr. Castell, please go to bundle 1 and go to page 56.
Thank you.
If you just take a moment to orientate yourself, Mr. Redfern, this is the IMT in question. And as I indicated, you were not present. And if we go, please, over the page to page 57, and if you go to the bottom bullet point, BG and DM, have you got that?
Yes. Yes, sorry.
DG and DM queried if the concerns of the clinical teams relating to the environmental risks in 2A had been communicated higher. TI explained that she shares these concerns and had been indeed reported these to the highest level in GGC and HPS over 2 years ago. DM and BG felt dissatisfied that there had been any response from senior management or out with GGC, which offered reassurance to clinicians. Do you see that?
Yes.
Do you have a recollection of any discussion of that matter around that time?
And I do not.
You don't. Would you agree that it appears to indicate two things? First of all, that Teresa Inkster is saying that she had previously raised concerns at the highest level, and that secondly, there had not been a response and there was a dissatisfaction around that. Would you agree with that? That's what that suggests?
Yes, I think that's what that wording says.
Yeah, and are you saying that you don't recall whether you were made aware of this, or are you saying that you weren't made aware of this?
In the period of when we moved into the hospital to this IMT starting off, I wasn't aware that there were issues outstanding between senior management and clinicians around infection control issues.
Okay, so if we that's the first point. So if we take that first point as to whether there were outstanding concerns, we've had some evidence that at the end of 2017 and previously, there had been concerns raised by infection control about aspects of the environment. Can you say whether that's something that you were aware of at the time?
No, I wasn't made aware of that.
Is that something that you ought to have been aware of, do you think?
Yeah, yes, because I think as we went through from this IMT to thereafter, it was important from a good engagement with clinicians and a good engagement in terms of how we were going to deliver services, that relationship and that information was there, yeah.
Yeah, so just to be clear, are you saying that as far as the previously raised issues, are you agreeing that that's something that you ought to have been aware of prior to then?
Yeah, I would have expected to know that.
Yeah. And as far as the expression of dissatisfaction, just so I'm clear, I'm understanding your evidence, as far as the expression of dissatisfaction, which appears to involve Dr. Inkster, Dr. Murphy and and Professor Gibson about an absence of response, are you saying you don't recall or you do recall that dissatisfaction?
I did not. Well, first of all, I'm assuming that the dissatisfaction was not with myself, because I didn't have anything that I had been asked of to respond to, because I've just outlined I was unaware of this. The second thing is clear that as we went into the IMT, all these colleagues had articulated that position.
Yeah, I mean, it goes on to say that TI encouraged clinicians to share their concerns with senior management and reported that this incident has been reported and so on and so forth. Have you got a recollection of these concerns being shared with you about this time?
Yes, because that was us moving into that AMT and I was actively involved through that process thereafter.
Right, so are you saying that you do have a recollection of a concern about an absence of response being raised with you at that time?
Through the IMT process, it became aware that there were issues and the clinicians were unhappy, yes.
Okay, thank you. Now, we can put that to one side. And what I want to do now then is to focus on the other aspect, which is the communication with patients and families. Now, we have already seen almost all of the IMTs here, and I'm going to try and avoid looking at documents that we've seen before. And I think it's also clear that as far as the early IMTs on the water incident are concerned, I think the first three don't record you as being present. And if I just give you the dates, you can maybe tell me whether that would accord with your recollection. So we've just looked at the one on the 6th of March. I think the first one was on the 2nd of March. And then there's the 6th of March, and then one on the 9th of March. And it looks as if you weren't present at those. Would that accord with your recollection?
I can't remember back to those times, specific times. But yeah, if I'm not there, then I'm not there, because accurate minutes would be taken each.
There have been observations made already in the evidence about the accuracy of minutes, and I don't think any criticism was intended of the minute taker, but did the IMT minutes always faithfully record everybody who was at IMTs?
Well, they should, yes.
They should, but did they?
My understanding was they didn't. We would have a chance to go through subsequent IMTs to check the minute was accurate.
Yeah, thank you. Now, if we move then to the first one that I think you attended, and Mr. Castell, could we stay in bundle 1 and go to page 63, please? And again, Mr. Redfern, if you just take a moment to orientate yourself, you'll see it's an IMT of the 12th of March, and I think we see you recorded as being among the attendees. And I just, we've looked at these before, so if you'll forgive me, I just want to go to the part
That's
about
okay.
communication, just to understand what was going on at this point. So if we go, please, to page 65, and it's the top half of the page. Hopefully that's sufficiently enlarged for people. You got that, Mr. Redfern?
Yes.
We see Emma Somerville and Professor Brenda Gibson have updated all the family's patients on Friday night. And then below that, in relation to press, there's a discussion about Dr. Inkster, you, Jen Rogers, and so on and so forth. You see all of that?
Yes.
Can you say whether that indicates that at this stage, it was the clinical staff who were doing the updating of the patients at this point?
We would, yes, clinical staff would always be updating the patients in terms of just a consultant to patient relationship.
Yeah, I mean, I think and does it indicate that your involvement would be more around the press statement side of things?
Yeah, I would be trying, at that stage there, we'd be trying to articulate what that position was in association with the views of the senior charge nurse and the consultant who were attending the IMT.
And when you say I would, does that mean you don't have a clear recollection of what exactly happened at this time?
But, well, again, I can't remember going back to the actual IMT, but I would expect, and yeah, I would say I would fulfil that. I have confidence I would have fulfilled that duty out.
Yeah, the question I'm asking is if this part of the IMT might be read as indicating a division of tasks with Emma Somerville and Professor Gibson dealing with the patients and the parents and others dealing with the press. Would that be what was going on at the time?
Not necessarily, because the way that we worked at that stage in the IMT process was that although Emma and Brenda would have that direct contact with the patients because of the roles they had, if there were any concerns that a parent or family had, that both myself and Dr. Inkster would have been more than welcome and actively would have spoken to them.
Yeah, thank you. Now, I think the evidence that we've had from two of the nurses who gave evidence last week is that I think their recollection is that it's rather later in the events that you and Jennifer Rogers become more actively involved in the process of directly communicating with patients and families. Can you say whether that accords with your recollection? When we moved towards 6A, there was a much more proactive approach to releasing statements and going round every single patient rather than an opt-in. However, I did speak to specific parents prior to that in Ward 2A with Dr. Inkster and Professor Gibson because of the request of individuals as part of that process I've described. So the general sort of how this functioned was we would have the IMT. There were patients who were directly linked to the IMT because of the infection. If any of those parents had a query that they wished raised that neither of the senior charge nurse or Professor Gibson felt that they could answer, then Dr. Inkster and I would make ourselves available, and that option was picked up. But it is fair to say that as we went through the IMT processes, that changed from an opt-in to Jen Rogers and I actively going round every single parent on the wards to update them on where we were with
that relevant IMT at the time.
And I think I understood you to say a moment ago that that approach of you, as it were, proactively doing that is something that you associate more with once you were on 6A, is that right?
Yes.
Yeah. And if I tell you that also accords with the recollection, I think, of at least
There
one of the nurses.
was a definite shift in terms of how we communicated with parents.
Yeah. And as far as opt-in is concerned, that's a phrase that you use in your statement. Opt-in communication is what?
So by that, when Brenda was, two groups of patients that we're talking about here. The first group, those directly involved in the IMT. So there would be infected children who had triggered the IMT normally, and if there was any concerns that neither Professor Gibson or senior charge nurse or anyone within the clinical team, because Professor Gibson wouldn't necessarily be the consultant that was looking after all of those types of patients. If there was anything that they wished a senior manager to become involved in, then I would put myself forward for that and speak to those parents. If I've used the wrong words in terms of opt-in, my apologies, but it was that they were offered that opportunity and should have been offered that opportunity at all times to speak to. But we didn't proactively go beyond what Professor Gibson and Emma did, or the senior charge nurse of the time.
Thank you. And just to be clear, I'm absolutely not suggesting that you've used the wrong words, as you put it. These are your words. And and if you just bear with me, what I think you're saying is that opt-in means that if somebody wanted more information from management, that was available.
Yes.
Thank you.
And if I couldn't answer the questions they were asking, we would give a guarantee that we would go and get those answers for them.
Yeah, and just while we're on this, while we're discussing this at this sort of general level, I'm assuming that what you're describing relates to inpatients, is that right?
Yes.
What was the process at this point in relation to outpatients?
There wasn't really a process there for outpatients at that time.
Thank you. Now, if we move then a little further on in time, please, to another IMT at which you were present. It's page 66 of Bundle 1, please, Mr. Castell, and it's the 16th of March. Sorry, my lord.
My fault entirely. Mr. Redfern, in relation to outpatients, I have your answer as not really a process at that time.
Sorry, in describing what I've just described in terms of our inpatient speed, I did not do that for outpatients.
Right. And we're talking about March 2018, or are we talking about the later stage in Ward 6A?
In the later stages of Ward, when we were in Ward 6A, there was proactive approach to communicate to outpatients as well, yeah.
Sorry, you said inpatients.
So, sorry.
It's my fault. I'm really just concerned to understand at that time, so I'm following your evidence. The absence of process with outpatients applied in, I assume it applied in March of 2018.
Yeah, yes.
Are you indicating it applied after the decant to 6A or not?
It would have been round about the decant. I can't remember when the exact change in process occurred, but it was noted that there had been a focus on inpatient communications and that there had to be a change and that we had to make that change and include it to patients who were coming through for outpatient attendances and indeed who were not attending the hospital but could at some point in the future, depending on their illness.
Sorry, Miss. No.
Not at all. Thank you, my lord. If we move then to the 16th of March, please, Mr. Redfern, at page 66. Again, just take a moment to orientate yourself. It's an IMT, 16th of March, and I think we see that you're one of the attendees. And again, maybe just to help us a wee bit with the timeline, if we scroll down a bit, Mr. Castell, to underneath patients, and hopefully that's large enough for everybody to see, just stop there. We see that we've got 3 additional hospital-acquired bacteremia cases at that point. You see that?
Yes.
And again, I just want to move to the communications aspect. And if we go to page 68, and if we enlarge the communication section, thank you. And I'll just walk you through that again. We see that Professor Gibson and Dr. Inkster have spoken to one of the patient cases that morning. Is that right?
Yes.
And then Dr. Murphy is going to deal with another one, but it's really the next two paragraphs I'm interested in. All patient information has gone out to all current inpatients regarding the water issues. If any parent inquiries about receiving ciprofloxacin, they're to say it's just a precaution due to issues with the water incident. And I'm interested in that second aspect. What would you say that indicates in relation to communication around ciprofloxacin?
Sorry, could you repeat that question?
What would you say that the paragraph about ciprofloxacin indicates about the approach to communication of that matter?
I mean, this is a summary of a minute. It's given an instruction to whoever is speaking to the parents about how they would refer to the use of the therapy and why it was being issued.
Mm-hmm. Can you say whether it indicates that the organisation? Sorry, let me rephrase that. Does it say whether it indicates that the organisation's communication about the use of this drug would not be part of its communication with patients and families?
Sorry, say that.
Can you say whether this indicates that there would not be a communication about the use of this drug unless somebody asked?
I don't know the answer to that question, but I would have assumed that if Professor Gibson and Dr. Inkster were speaking to parents, then that would be explained to them.
Okay.
And if I was present, then I would have assumed that to be the case as well. And I'm not sure why I wasn't mentioned as being present at these discussions, because my recollection was normally there would be the three of us undertaking that. It was a clinician, manager and colleague from infection control.
Who would proactively go to the ward to have this sort of communication?
If the opt-in process was asked for, yeah.
Yeah, so that qualifies what you've just said. If asked, you were available. What I'm asking you is whether this indicates that a discussion about the use of ciprofloxacin would only occur if asked.
No, well, I would have assumed that the clinician to the patient, there would be an explanation for why a particular drug therapy was being offered.
Yeah.
And I would not, from my own personal perspective, I would not expect to hide from that it was linked to water supply, if that was the reason. That it was linked to water supply, if that was the reason. I would like a transparent process and would encourage that at all times.
Yeah. If it assists, the evidence from two of the clinicians last week said that they certainly wouldn't have been content with communication to their patients, where they simply said, "We're giving you this as a precaution."
Yeah, I would fully endorse. I would fully endorse the position that both clinicians took, and would encourage them at all times to do that, and would expect that in the excellent doctors that they are and the relationships that they have with their patients, that they would explain everything in full, and there would never be any instruction to them, and none of them would ever have taken that instruction, that they are nothing but transparent in terms of why a drug is being offered or a therapy.
And can you say whether it would be your expectation and wish that as an organisation, any communications that the organisation was making would reflect that approach also?
Yes, 100%. And I think through the IMT process, again, obviously a minute is a record of the IMT, but it won't catch everything verbatim. There would be a process when we were checking with the individual consultants of patients who were infected, or indeed a summary of the ward, that everybody was informed of what the situation was. They were aware of it, and that there was full transparency.
Okay, thank you. And just to complete looking at this particular minute, please, could you go to page 69? And just underneath press, if we enlarge that, we can see that there is a reference to a press statement in which the fact that 3 patients are affected is mentioned. And
Yes.
in the next paragraph, it says, Dr. Armstrong will speak to the Chief Executive, Jane Grant, to see if a proactive press release statement should be released. So I've got 2 questions there. The first question is, what is a proactive press release?
They release it before the press asks questions. I think I don't work in comms, but I would assume that's what that is.
Thank you, and I'm grateful for what you just said. You must indicate if you feel that these are not questions for you.
So I caveat that, but I think that is what that is, that they will make a release before being asked by the press about a specific matter.
Okay. And the second question I have around that is, as far as the process of agreeing communications, was it your understanding at the time, or rather, let me rephrase that, can you say whether it was your understanding at the time that the most senior directors and executive officers were involved in this process?
Yes, well, that's what the minute clearly states. And my experience at the time was that while you'd referred to in the earlier minute that we were looking at drafting briefs or media statements, whatever you want to call them, they would be forwarded up through that or through the organisation hierarchy for final sign-off.
Okay, thank you.
All press statements would be signed off through the corporate process.
Thank you. Now, I want to look at a couple of communication documents from this time, please, Mr. Redfern. Mr. Castell, could you take us to bundle 5, please, and could we go to page 112? And I wonder if we can just enlarge that a bit. Thank you. And I think we can see, if you take a moment just to have a look at it, that it says that NHS GGC are investigating the presence of bacteria in the water supply to wards in the Royal Hospital for children. These bacteria pose very low risk to anyone with a healthy immune system, but can pose harm to patients whose immunity is compromised. 3 children are currently receiving treatment for infections that may be linked to these bacteria found in the water supply. Tests are going to confirm if they are indeed linked. And then if I just ask you to pass over the quotations from Dr. Inkster, and you'll see a reference to Health Protection Scotland. Do you see that?
Yes.
And it then says, in the meantime, alternatives to tap water supplies to paediatric patients in wards 2A, 2B, 3C, and the hospital's intensive care unit have put in place. Given the low immune system of patients in these wards, we have also given them oral antibiotics. And what I should have done at the very outset is just identify this. This appears to be a media statement of the 16th of March. Is that right?
Yeah, from the date on the statement.
Yeah. And if we go over the page then, and just noting before we do that, that there's a reference in this to patients being affected by infections linked to the hospital and to the use of antibiotics. So if we go over the page, please, to page 113. Now, our understanding is that this is a communication to parents and carers as the note suggests, on the same date. And if you just take a moment to read that and tell me once you've done it.
I've read it.
Thanks. It appears not to include the references to infections and to the provision of antibiotics. Is that correct?
It doesn't mention it in the final paragraph.
No, thank you. Now, I think it's only right to say that, I mean, as far as we understand it, there are two communications to patients and families over this period, with the possibility of a third. It's not clear, but certainly from what we understand the position to be at the inquiry, this is what went out, or it bears to be what went out on that date. And I guess my question is this: are you able to say why it is the communication from the organisation to the patients and families contains less information than the information that was given to the media?
I couldn't answer that question. I don't know.
Well, can as somebody who was a senior manager at the time and actively involved in managing all of this, can you say whether that difference is explicable to you?
No. I would have assumed that information to the media would be replicated with the patients and should be as informed as it possibly could be.
Thank you. Now, if we move back, please, to bundle 1, please, Mr. Castell. And we go to page 70, please. And again, just to orientate yourself, it's an IMT minute of the 19th of March, and I think we see your name mentioned as an attendee. You got that?
Yes.
Okay, thank you. And if we go, please, to page 73. I beg your pardon, yes, 73, top of the page. Maybe we could enlarge the communication section. When you discussed earlier, or you discussed with us earlier, the recording of the communication strategy in the IMT, and did we see here that what's recorded is that there's a request for some sort of discussion in relation to the PICU, and there's a reference to the staff receiving updates, but there doesn't seem to be any record of any communication strategy featuring the patients and families. Is that right?
It follows the process I described before, which is when there was a patient who wished, or a parent who wished for further information, then normal circumstance would be that the consultant, the Dr. Inkster as the main infection control link, and myself would speak to them. So yeah, that was the main, at that time, that was the main process for how we would update individual families.
Yeah, thank you. If we move then, please, to the next IMT, which is the 21st of March, and it's at page 75 of bundle 1. And again, just to identify it, we see that you are recorded as an attendee.
Yes.
And just to pick up on one or two details from this one, if we go to page 79, underneath hypothesis.
Yes.
And forgive me, I'm drawing this to your attention simply because I don't recall that we've actually looked at this so far. I just wonder if you recall something along these lines. Dr. Inkster explained that Scottish Water and main tanks are negative, post-filtration tanks and risers are negative. The bacteria concerned, like oxygen in taps, showers, are heavily contaminated. You remember that? Or something?
Yes, I remember. Again, I'm not a microbiologist and I'm not an infection control doctor, but my recollection of that is that the water into the system was clean.
Yeah.
So it was a problem with the internal system.
And if we go over the page, please, to page 80. And we enlarge the top half of the page. Thank you. Again, we see the communication aspect. And would you agree that the record in relation to patients and families is concerned with really what is coming back from patients and families rather than what is going to them?
Yes, at the time, as I've mentioned, the approach that was taken was to use the words opt-in.
Yeah. And I wonder if you take a moment to look at what's said under the heading press and public, and if you look in particular at the second of the paragraphs that refers to Mr. Dell, can you indicate whether that suggests a concern that was coming from somewhere around the approach to communication?
That's what that paragraph says, yes.
And that reference to a lack of transparency, is that something that you recall became a feature of concerns at that time?
I can't specifically remember that particular comment at that IMT. I certainly can't remember ever, in terms of feedback, where there was a lack of transparency in that what we were offering Dr. Inkster, the clinicians, or myself. I don't know whether there was anything further up organisationally. I don't know. I can't remember.
If we
I certainly think the provision I described, there was nothing but transparency. There was obviously the limitations of what we knew, which might be that we were, and what we didn't know at the time, because we were working through hypothesis, and what the problems were and what the solutions would be. So you can only report what you know at that particular time, and that might have felt that there was some issues of transparency. I don't know.
Well, we've seen, just on that point, we've seen that around this time there was reporting going to the media, which included an indication that there were infections that were thought possibly to be linked to an issue with the environment, and that there was the prescription of prophylaxis being given. And we've seen that that was not being said in the handout, at least the one that we looked at that time. We just wonder, against that background, whether you have any thoughts as regards of whether a concern about transparency might be understandable.
So I right through the whole process of every IMT as part of this public inquiry into the Children's Hospital, I never ever felt that there was a lack of transparency. I never ever felt that, and I would never ever have allowed that to happen personally from myself. I always felt that everyone spoke truthfully, honestly, articulately, as much as they possibly could on the circumstances at that specific time, and that is my honest opinion. As I've said before, the IMT reported upwards on everything that was being discussed, and as far as I'm aware, the IMT minutes go through the board's infection control processes right up to board meetings and are published. So I always worked on the basis that the organisation was being as transparent as it should be, but further up the organisation in terms of media statements and whatever, I can't answer. I don't think intentionally MD would have excluded a particular bit of information, but that's just my general feeling of the culture within the organisation.
Well, that would be a question for somebody else, not
Yes.
for you, is that right?
Yes.
Yeah. Well, what I'm asking you really are two questions. First of all, looking at what's recorded here, can you say whether you recall that there was a concern coming from patients and families about a lack of transparency?
There was unhappiness, yes. There was unhappiness and because of the circumstances that patients were and parents were having to experience. Of course, it was a horrible set of circumstances that they were dealing with in terms of the precautions that had been put in place. Whether it transpired that we were showing a lack of transparency, I can't formally remember that, but I do remember there being general unhappiness about the whole thing.
Yeah,
and quite rightly, it was not a good set of circumstances to be in.
The question I was really asking you was this, Mr. Redfern, just try and confine yourself to the question. If you don't understand it, just say.
Yeah.
What I'm asking you to do is cast your mind back and to say whether you recall that there were concerns from patients and families about the transparency of communication.
I think there probably was from memory, yes.
So that's the first question. And the second one is when we go back to just think about those two communications that we looked at and the fact that there seemed to be less being said in the one to the patients and families, can you say whether or not you consider that the concern about transparency might be understandable?
I think the way you explain that, yes, but I would still go back to the point I make that a parent would, with the relationship with either their individual consultant or through the discussions with Dr. Inkster and myself, that we would be fully upfront and transparent about any, well, you're speaking about the prophylaxis. I think that we would be explicit about why that was there. I cannot believe that a parent would not know why their child was getting prophylaxis. And I think you'd agreed you'd said that the consultants agreed that. So organisationally, we were providing that information. Whether it should have been in the media statements is for the people who prepared those media statements.
Well, what about the? So let me take this in stages. I think what you're saying is that at this point, the organisation was relying upon its clinicians and its nurses to provide the necessary information. Is that right?
I think clinically that would always be the case, but I think also with the opportunities that I've described from a management perspective and also from an infection control perspective was there.
Yeah. But the principal mode of communication in relation to clinical matters and also concerns about the environment at that time, I'm taking you to say, was through the clinicians and nurses. Is that right?
That was the initial gate of entry in terms of day-to-day communication, because obviously they are having day-to-day interactions with children and families on the ward.
Yeah, and you've talked about one aspect of the communication that we were talking about, prophylaxis. The other one that we saw mentioned in the media communication was the existence of infections on the ward. And are you saying that it was being left to the clinical and nursing staff to make a judgment on whether they should tell patients and families about infections that other patients had on the ward?
Well, obviously there's patient confidentiality about anything, but I think that when we were in the situation we were in and why we had these precautions, of course we'd be explaining to all families why those precautions were being put in place. I certainly wouldn't just rely, and I can't remember the specifics at the time, we would have a visible presence on the ward. We would be walking about, speaking to people at the time, both Jen and I, and that we would, it wasn't just that the senior charge nurse or consultant would be left to explain that whole process. No, I don't think that would be fair.
Well, the question I was really asking is this, and we'll move on in a moment. We've seen that there was an agreement at the IMT that the media briefing would include mention of the fact of there being infections, and we've seen that there was mention of that in the media briefing. So a decision has been taken somewhere that that's appropriate. Is that right?
Yes.
We don't see any recorded instruction to the clinical staff or the nurses to tell patients that there are other patients who have infections. Is that correct?
If there are no documentation of that, then that must be correct.
Yeah. And indeed, one of the clinicians last week did emphasise the anxiety that they would have about that sort of discussion. Would that accord with your understanding of how you would
I
approach
could
things?
fully understand if a clinician felt uncomfortable with that, but that's the whole position that I had articulated earlier, that when they were in that situation, then I was available to speak, as was Jen Rogers.
Yeah, but that would mean, if we just follow my train of thought, that the organisation would be entirely relying upon the discretion of the clinician as to whether or not the clinician mentioned that there were other infections in the ward. Is that right?
Yes, yes.
Thank you. Right, now moving on, please, if we might, if we go, please, to maybe if we just think about, no, actually, sorry, if we move on to the next item in the bundle, please, the IMT minute of the 23rd of March is at page 81. Again, take a moment to orientate yourself, please, Mr. Redfern. You see that you're present, and again, just to pick up some references, please, if we go to page 84. Again, I just want to pick up on something that we may not have looked at. Under hypothesis, Dr. Inkster, have you got that?
Yes.
Dr. Inkster has found numerous pathogens predominantly found in soil and plant material. It's very unusual to see this. Do you have a recollection of a discussion around those terms? And what about the next paragraph? Facilities have informed the group that this could have happened during the commissioning period. Do you have a recollection of I have a recollection of all of this conversation. So that was the advice that was coming at the time, is that right?
Yes.
Yeah. And if we go to page 85, the top of the page, communications, again, does it appear that the discussion of communication is around what was coming from the patients and families rather than what was going to them? Is that right?
Sorry, say that again.
If you look at the section on communications, patients/parents, no concerns from patients' parents with the RHC, is that right? You got that?
Yes.
I wonder whether that indicates that the focus was on what was coming from the patients rather than what was going to them. Would that be fair?
Yeah, you could make that assumption.
Yeah. And finally, just to conclude this section, please make sure we've seen all the references. Could we go, please, to page 86? And it's, again, if you just take a moment, Mr. Redfern, do you see you're mentioned as one of the attendees?
Yes.
And I don't know whether you remember this one, but our understanding is that this is the point at which this IMT closed, I think. Would that be right?
I would need to go through the IMT, but yeah, the timeline looks about right.
Right, thank you. That's something we can perhaps pick up on later if we need to. Now, we've had a bit of evidence already on this, and I won't take up your time on it. And the evidence is it's recorded in the IMT that there was a report of a widespread problem in the RHC with pathogens and fungal sites being found on both sites. Is that your recollection of what was said? Yeah?
Yes.
Now, if we go, please, to page 89. Just a detail I'd like to pick up on here. Underneath, update on contingency plans. And I just really want you to have a look at the first paragraph, the one concerning you, and just have a read at it and then let me know when you've done that.
Read it.
Thank you. Can you tell me what this is about? What are the
Okay,
contingency?
I'll summarise this as best I
Thank
can.
you.
So the IMT had worked its hypothesis of the problems that will have been documented in the minute. The solutions, what follows once we've got hypotheses, is solutions that need to be put in place. The solutions at this time, to my knowledge, were that we would allocate filters to the taps, and that we would at a later stage look to treat the water. The question being posed here was what would happen if the filters failed. There was strong emphasis from the supplier at the time that the filters would not fail, and this was backed up with all their academic and other reporting of the adequacy of the equipment that was being put in place, and that, to my knowledge, there was no other contingency beyond that as we went through that process. So there was a reliance on these filters working while we treated the water.
Okay. And
the filters did, from there, do their job.
I suppose my question might be this. What was it about this group of patients, and what was it about the hospital that required there to be a contingency plan from your perspective?
Because patients were being infected. So we had to try and minimise the risk of infection. That was the whole purpose of the IMT. I suppose what I'm trying to say there is that we've worked out a hypothesis, we've put solutions in place, but if those solutions don't work, then what is it that we're going to do thereafter?
Okay, thanks very much.
I suppose it's it's a managerial question to clinical colleagues.
Thank you. And if we just look at the section a little bit further down on communications, no concerned parents at the moment, but the longer this goes on for the BMT patients, the more worried about the inconvenience. And there's a concern that you've raised, but again, I don't think we see any communication strategy as such for them. Is that right?
Yes, it's not mentioned there. So,
and again, that would be in keeping with everything you've said.
Yeah, I mean, I think I suppose what I was trying to get across in terms of where we were with this, it was, again, incredibly difficult circumstances, how we were putting solutions in place. Ultimately, until we got the filters and the treatment solutions identified, and it was how you managed that whole time was very challenging. But yeah, there's no reference to media statements, as you say.
No reference to patient statements.
Patient statements, sorry.
Thank you. Now, I want to look at another document that we've not looked at yet during the inquiry hearing, and it's just, again, just to try and bring it out, if you don't mind, and just to get your reflections on it. And it's in Bundle 8, please. It's at page 53. And if you just look at the top of the page, it's Full Incident Management Team Report, and the author appears to be Dr. Inkster, and it refers to the date of a first IMT meeting, 2nd of March, and a last one, the 13th of April. Do you see all of that?
Yes.
Is this a document you've seen before?
I can't remember.
Is it a style of document that you're familiar with?
No.
Does it appear to be even just, and do say if you can't help us with this, do you know whether it appears to be a review of the well, as it describes it, a full incident management team report. Does it appear to be a review of what went on?
I'm looking at the document. It looks like it's a PAG report.
Okay.
From that, yeah, that's what it looks like. So I have seen that type of document. Sorry.
Okay. And well, maybe what we should do is, especially as you're not sure whether you've seen it before, I'll just take you to passages in it, and you can tell me whether it jogs your memory, and you can also maybe tell us a bit about whether it helps you with the sort of document this is, and the purpose it might serve. Does that seem fair?
That's okay.
Okay, thank you. So if we go, please, to page 54. And we just enlarge the top half of the page. It says, under sources of next to sources of exposure, it says contaminated water supply. You see that?
Yes.
Duration of incident from the 1st of March. And then it says complex incident, contaminated water supply, long-term preventative measures will take some time to implement. This report focuses on the acute incident and any learning from that. You see that?
Yes.
And again, just if we go further down the page, please, just to the foot of the page where it says areas of incident occurrence, initially Ward 2A, then throughout RHC and QEUH. You see all of that?
Yes.
Now, again, just pausing, seeing these references, does this jog your memory at all as to whether you saw this?
So there's two things. First of all, is if this was a representation of a PAG meeting, then the PAG is primarily to the IMT, and will normally either trigger an IMT or say there is no need for an IMT. So I'm familiar with that process. I'd certainly would expect to be aware if there was a PAG happening and get feedback, not necessarily always getting the documentation. I would hope that I would get that, but I can't recall a specific bit of information. But I was aware of, certainly at the time, but we were all aware because we all became involved in the IMT that followed.
Thank you. Now, I think in all fairness to you, Mr. Redfern, I should say to you that we have a bundle of PAGs, and that was based upon what we were provided with by the Health Board, and this is not among them. So that's the first point I would mention to you. And the second point is, this rather looks to me as if it's a review that comes after the IMT process, which would maybe suggest that it's not a PAG. Would that be... You want to have a think about that?
Yes, I think that's correct.
Okay, well, we'll continue going on, and if there's any particular bits that we look at that you think are of assistance on this question of what this is, do tell me. So if we go to page 55, we see, if we go further down the page to main conclusions, and enlarge that so that everyone else can see it, thank you. Possible all cases are linked to water as links in time, place, person. We just haven't found the strain as yet. Typing continues. And again, just thinking back to your experience through the IMTs, can you say whether what's set out there accords with what your understanding was at the time of the working hypothesis?
Yes, I think that is correct.
Yeah. And if we go over the page, please. Overall summary from investigation. Water testing revealed contamination of water supply within RHC and QEUH. You see that?
Yes.
And again, can you confirm whether it's your recollection that that was the advice that was being given at the time? Is that right?
Yes.
Yeah. And the hypothesis was contamination took place during installation and is built up in the system, creating thick biofilm. Again, can you recall whether that was what was being said during the IMTs? Yeah. I don't know whether it's my fault or your fault, but more probably realistically both of us, but I've noticed that we're starting to sort of talk across each other.
Sorry.
No, I tend to ask long questions. So if you let me finish the question and then answer, and I'll try and shorten my questions. Thank you. If we go to page 57. Now this picks up on something you said a moment ago. Main conclusions, if we enlarge the top of the page. There's no further bacteremias. Therefore, control measures were deemed successful. Is that right?
Yes.
And again, just so we're clear, does that accord with your recollection that the IMT finished after the point of use filters were on and there were no further infections being seen? Is that right?
Yes.
Thank you. What about the reference before that? Filters are a short-term measure. Do you recall that being said?
I can't remember it specifically being mentioned as a short-term measure, but the understanding was that further solutions thereafter would query make whether or not the filters were required. I don't know whether we would have said that as a short-term measure, but certainly if the water was treated successfully and that through further testing the water was clear, then filters would naturally not be required.
Thank you. If we move on to the next page, I'm sorry, just before I do that, just to be clear, what you've just said, was that your understanding of the advice at the time about filters?
Well, that would be a natural position to take, yeah.
Yeah, thank you.
You wouldn't need filters if the water was successfully treated, as repeat tests showed that it was clear.
And in all fairness to you, if you just look at what's said below that, long-term measures, is that essentially setting out what you've just said?
Yeah, so we've been asked on, probably be picked up later on, but we've been asked through the duration of further communications with families when we've said that the water is safe, you can drink from it, you can, the parents have asked, well, why do you have filters?
And what is the answer to that question?
It's an added precaution, but ultimately probably is not one that is needed. Well, not probably. If the water is, if the testing from the water is that it's clear, then you do not need filters.
And I think
filters are there to protect you from a dirty water supply, is my understanding.
But nevertheless, if we look at the long-term measures, do we see the fourth one is the use of filters on the long term in high-risk areas? Is that right?
That's what it says, yes.
Yeah. So was that your recollection that even with those other measures 1 to 3, measures 1 to 3, the advice was the filters would have to remain in high-risk areas?
Yes, at that time, yes.
Thank you. And if we go over the page, please, to page 58. And if we enlarge the top half of the page, under summary, it says evaluation of impact and achievement of objectives, concerns expressed regarding the lack of comms from clinicians. Now, I'll ask you again, reading that, does this jog your memory as to whether you or not you've seen this document before?
I cannot specifically remember reading it, but I am sure that I will have.
Thank you. And is it your recollection that there were concerns being expressed about the lack of communication?
I think that there was obviously concerns around communication because we made changes in terms of the process of how we as an organisation reported the further IMTs and problems that we had.
Yeah, and I know that you didn't draft this, and your recollection of reading it is not clear, and you may consider this an unfair question, or at least not a question for you. But insofar as it refers to from clinicians, would it be your expectation that that refers to concerns from the clinicians about communications?
Yes, that would be my interpretation of that comment.
Thank you. And as far as main conclusions, challenging incident with high anxiety, is that an assessment you would agree with?
Yes, and I think that's articulate of the situation that was faced at the time.
And just it goes on to say, difficult balance with releasing info and not causing undue alarm to be discussed further in the debrief. And again, can you say whether or not that reflects your assessment of
Yeah, I think there is always a balance between there, and that comes across in every IMT, and that's why you make a decision about whether you release information or not, and there's a formal process for how the IMT comes to the conclusions that it does around release of information.
Yeah. And then I just noticed something that says under the section antecedents of outbreak, Mr. Costello, if we could just scroll down a bit. And if I have you look at what is the likelihood of a similar event occurring? And it says high in a new build hospital. Have you got a recollection of seeing that or that being said at the time?
No, I can't remember that. I can't remember that comment.
Thank you. Now we can put that to one side. Thank you. Now, we spent a few minutes looking at it, and you've had an opportunity to consider whether you saw it, and I think I took you to say that it's likely that you would have seen it. Is that right?
It looks to me like it's a debrief of the IMT.
Yeah.
Or IMTs.
Do you know what, if any, response there was to it from management?
In terms of the actual paper, or
Yeah.
I can't recall a formal response from the organisation.
What, you can't remember whether there was one?
Yeah, I don't know. I wasn't part of a formal response.
Okay. So are you able to say whether or not there was any sort of review at senior managerial level on what we've just seen set out?
In terms of that previous IMT, yeah, because there was an ongoing process for how we resolved the situation.
Well, if we take a step back, can you say whether you agree with me that report that we've just been looking at sets out what might be described as a number of learnings from the incident?
Yes.
Do you know whether there were any steps taken to address and review those learnings?
I don't know.
Okay.
That would be within infection control and other corporate departments, not operationally at my level.
Yeah. I mean, in your statement, you described the organisation as a learning organisation. What do you mean by that?
I think we learn from our experience. That's what I always look for in my own practice. And I think that's demonstrated through this IMT in terms of how I communicated with parents and families.
So would it be your expectation, just picking up on what you've just said, that there will be something that followed upon this and indicates a review and an attempt to learn from what had happened?
Yeah, I would assume that would happen with all IMTs, but my understanding would be that would be through infection control and prevention.
So that would be...
Are led through that process.
So what about on the managerial side? Where would a review of these kind of reflections,
when I say infection prevention control, I mean at a corporate level with corporate instruction around how you would take forward, you've received this document and what you were going to do with it.
Thank you. Now, we're going to move forward in a minute to look at the summer of 2018. But before we do that, I just want to just think about your reflections on communication with patients and families over the period that we've just been looking at. And in your statement, you indicate that you are aware that there were criticisms, and you say that the organisation has learned. What do you mean by that?
I mean, we changed our approach to how we communicated with people.
What was it you thought that you hadn't got right?
I think the lack of media statements, statements to families being issued formally as opposed to the opt-in approach, and we changed that.
What about the appearance? And we've only just looked at one. I quite accept the appearance of a difference between what was being said to the media and what was being said to patients and families. Do you know whether that was something that was looked at?
to be honest, I cannot remember ever thinking we were telling a different narrative to the media to what we were telling parents and families at that time. That is not something that would be coming into this inquiry, answering these questions that I would have, that I would have thought was happening.
And just
it certainly was never instructed to me that that was what was happening, and I don't know. Others will have to answer the different statements that were issued, but I cannot ever remember that we would say that there was any communication informally to me that we were saying something to the media and saying something different to families. That is not something, again, that I would be comfortable with.
Okay, thank you. If we move on then, please, to the summer of 2018. Now, again, we've had quite a bit of evidence on this already, Mr. Redfern, and I'll maybe just lead you a little bit at the start. If you want to go to a document to clarify something, we can do that. And similarly, if you want to go to your statement, we can do that. But our understanding from the IMTs that we've seen and the evidence that we've had is round about the start of June, and we know that there was an IMT on the 4th of June 2018. There was evidence that there were further gram-negative bacteria cases emerging. Does that accord with your recollection?
Yes.
Yeah. And we've had evidence about clinician concerns about 2A, that they were not comfortable admitting patients, and that the prescription of prophylaxis had to be reinstigated. Does that, again, accord with your recollection?
Yes.
Thank you. And the clinicians have explained to us that their understanding of what was being said, and I emphasise, Mr. Redfern, we're only interested in what was being said, not whether things were or were not accurate. Their understanding of what was being said is that it was thought that there was a site-wide issue with the drainage system. Is that your recollection?
Not my understanding of the situation in terms of this particular group of infections was that as we went through the IMTs, there was an unintended consequence of the implementation of filters and a splashing effect coming from the drains, and that as a response to that, I'm sorry if I'm going a bit further along, as a response to that, through the IMT, it was identified that the sinks had to be replaced. Whether that was an overall problem with the drains, I can't remember all at that particular point in terms of solutions and operational being able to deliver a safe service, was that the sinks had to be removed and changed, and that was what ultimately we moved to.
Thank you. Now, just maybe helping you a bit with what you've just said and helping us in turn, why don't you have a look at your statement, please? And it's at paragraph 86B. Mr. Costello, I wonder if we could get this up on screen. The statement bundle is page 389. It might just help people to see this. So it's paragraph 86. And it's B. You see that?
Yes.
Is that what you've just been describing?
Yes, that's that. To my mind, that was the if I could summarise it in terms of where, as a non-microbiologist, non-clinician, where I was coming from was we had a problem with the water supply. We put filters in place to treat that problem. They worked for a period of time. There was then a second round of infections, which we went through an IMT process, which identified that there was to all intents and purposes, in my mind, what was described to me was a splashing effect because of the proximity between filter and sink, which was creating infection or risk of infection to the children. And the only solution was to remove the sinks and make that distance greater to nullify the risk of splash. And to do that, we had to move.
Yeah.
So that's my summary of what was described to me, and what led ultimately to us moving toward 6A.
That's helpful, thank you. you've given us one bit of the jigsaw, which is the role of the filters in this. What we'd had evidence of thus far is the other bit of the jigsaw, which is as regards the sinks themselves. I think the evidence that we've had from the clinicians is that what they were being told is that there was site-wide concern around contamination within the sinks or within the drainage. Is that your recollection?
So there was obviously some sort of problem underneath the sink because a splashing coming from a source was leading to infection.
Yeah.
So yes.
Yeah, so it's the combination of the two things with
Yes.
your understanding, is that right?
Yes, but in the context that I am not a microbiologist and I'm not an infection prevention control doctor, the primary focus I had at the time was in terms of how we minimised the risk and how we provided a safe clinical environment.
If I reassure you that everybody last week provided similar caveats, that they weren't expert on these matters, and I say that simply again to emphasise, Mr. Redfern, I'm just interested in understanding what people were being told.
So there was so from my memory of what we were being told was there was this splashing effect. There was a problem underneath the sink, which was creating the splashing was leading to a risk of infection, and the sinks had to be changed.
Thank you very much. That's very helpful. Now, if we start to just look at one or two of the IMTs in this period, and we'll see if we can try and take things up to more or less the point of the decant before we have our mid-morning break. So if we could go please to the IMT on the 6th of June, which is at bundle 1 again, Mr. Castell, and it's page 99. And again, just orientate yourself and see that we're looking at an IMT of the 6th of June that looks like that you attended. And it's our understanding from the evidence that we've had already that, as I've indicated, that around this time there were further cases emerging. Would that accord with your recollection?
Yes.
Yeah. I really just want to look again at the media and patient communication aspect. So if we could go to page 102, please. The foot of the page, the press office were approached by the Evening Times, so a press statement was released yesterday. Media have run exactly what was put out with the addition of some quotes from patients' parents. So far, there's been no media interest today, no media update will be sent out today, but may get some follow-up questions from the media in the next days. And if we go over the page, advice to public information was given to parents who have patients in Ward 2A and 2B regarding the HPV clean. You see that?
Yes.
And if I just reassure you that in the redacted section, there's nothing that is germane to what we're discussing. It's to do with an individual case. So there's a reference to advice being given, or rather to information that there's going to be HPV cleaning. And I think we understand HPV to be hydrogen peroxide vapour, is that right?
Yeah. Yes.
But again, sorry, and if we just go a little bit further down the page, assurances moving forward. Says Jamie, have you got that?
Yes.
So there's a reference to an executive group chaired by Kevin Hill, which will meet. What was that group?
That group never ever took place. It was what we were trying to do was allow the IMT to function on IMT business, and where there were operational issues in trying to implement what the IMT were putting forward as solutions, we would spend more time on that. But it was actually felt it was a duplication, and it was the same people in the same meeting talking about the same things.
Okay, so there were no meetings at all of this group?
Not that I can remember.
Okay, thank you. Now, if we look at, again, some communication documentation from this period, could we go to bundle 5, please, Mr. Castell? And if we go to page 139, just take a moment to read that and then I'll maybe ask you some questions about it. Okay,
Yes.
thanks. Now, again, I have on board the caveat that not only are you not a specialist in water, you weren't involved in drafting this. What I'm interested in, though, is your reflections on it. It appears to indicate that the media are being briefed that there was bacteria being found during testing. Is that right?
Yes. That's what it says.
And that bacteria can be harmful to those with compromised immunity. Is that right?
Yes.
And is it indicating also a link to the earlier issue with TAPS? Is that right?
Yes.
And the families are going to be informed. Is that right?
Yes.
Now, if we go, please, to a communication from 3 days later, which is at page 142. And if you just take a moment to read that and indicate to me once you've done that.
I've read it.
Thank you. Now, there's no mention of the bacteria, is that right?
Yes.
There's no mention of their harmful nature, is that right?
Yes.
And I wonder whether you think that this indicates that the issue might be something to do with people putting things down the sinks.
I think that it's an instruction to families not to do that, yes.
I wonder whether you think that somebody reading this might think that the cleaning of the drains was down to something to do with people putting things down the sinks.
Yes, you could take that. It's not as explicit as in the previous media statement that you said.
Well, it's quite different, isn't it?
Yes.
Are you able to explain the difference? You're
Sorry, no. But I would re-emphasise that I cannot remember and cannot certainly did not come into this inquiry thinking that we were telling one narrative to the press and one narrative to parents. Although that maybe is what I think you're highlighting, that was not my experience at the time in terms of interaction or with staff.
As you said earlier, in due course we'll need to speak to those who were actually running communications.
Yes.
But you are on the front line. And
yes, I was.
You are able to give us an informed view of what was going on. And so what I'm asking you
So
is,
when I, sorry.
Yeah. I mean, it's really a repeat of what I said earlier. Looking at that difference in communication.
Yes.
I wonder whether you think it would be understandable if a parent perhaps thought they were not being told the full story.
I think that there is a difference between the two narratives that are on paper. I think what I would say is that working with the clinical teams and myself or Jen or others on the ward with staff, we would have been more explicit about the issues that were being faced, because we would provide debriefs from the IMTs, which would potentially have been verbal, but we would certainly have been articulating what was coming from it and what we would be answering any questions that were posed of us, either informally or on a formal basis. And that's where I mean that there was no lack of transparency from, as you say, me at the operational end that was delivering that message. I never have, and I never felt corporately under instruction not to do that.
This is at a point, as you've already said, where you're still working on the opt-in approach, is that right?
For formal, but we would do walkabouts. We're a visible management team. We would do walkabouts in the ward.
Yeah. Now, I think it's important when we're looking at these pieces of paper that they have dates on them and we have an understanding of what their purpose is. But I entirely accept that at this point, we maybe don't know precisely what they are when they were issued. But on the face of it, this bears to be something that had been prepared by the organisation, setting out what the organisation intended that patients and families be told on the 7th of June. Would that be your assessment?
Yeah, that's what that's the document. That's the document. That's what would have been issued to them. Yes.
Yeah. So again, if you just go back to really my question, I mean, forgetting about what you may or may not have been saying in your opt-ins and what clinical staff may have been saying, and just thinking about the organisation's position. I wonder whether you think that a parent who saw this and then saw a media report based on that briefing with that additional information, I wonder whether you think such a parent might well think, I'm not being told the full story.
I can't, well, if I put myself in the position, if I was a parent, then yeah, I may reach that conclusion.
Thank you. My Lord, I think...
But again, I really would like to stress that I don't think that was a narrative that was being set organisationally, certainly not to myself or to Jen Rogers or anyone. There was never any instruction to limit what we were saying to them.
Where did your instructions come from as regards communication?
Just from the IMT and feedback from the IMT. I would always feedback to staff what the position of the IMT was, and what I've described to you in very layman's terms about splashing and sinks was clear to everyone. And I certainly would never have said that we don't disclose this or we don't disclose that. That's my general feeling from whether it was informal instruction or whether it was just how I presented information to staff and to families with regards of what was going on.
Thank you, Mr. Redfern. As Lord Brodie indicated, we normally take a break around now, but I think I might just try and squeeze in a couple of questions and at least move us on to July 2018, if I can.
Yes.
So before I do that, just a point of detail that I would quite like to pick up on, my Lord.
Mr. Duncan, before you could do that, could I just maybe square off what Mr. Redfern's evidence is on this matter? You've drawn attention to the terms of the update of the 7th of June. Mr. Redfern, you accepted that just on the basis of that update, a parent might
Yes.
come to the conclusion they were not being given as much information as was being generally disseminated through press statements. Now, but you wanted to emphasize that there was never any instruction, and that's how I've noted it. Now, is that instruction to you or instruction by you? It's my
instruction to me, instruction to me, or instruction by me. I would always be as transparent as I possibly could be. And I think what I'm rightly or wrongly maybe trying to take from the line of question and the comparison of the two documents is that, yeah, when you look at both documents, they are different in their narrative. Clearly, you can just do that by reading them. But in terms of actual, as an organisation, what we were saying to parents and families at the time, or what I was certainly saying, was not that there was any ever instruction for there to be that difference or for us to not tell parents and families specific bits of information.
Mr. Duncan asked a question which I don't think I heard an answer to. Where were your instructions coming from? Did you ask that question?
I did, and I understood you to answer it. I don't know how you want to approach this, my lord.
Perhaps just...
The IMT.
Right. Yeah.
Where I come back to with all the, because there's a fundamental issue here about transparency, I think is what we're talking about, is that the IMT is a formal process that the organisation has. It is properly minuted. It goes through the organisation and is up to board level. And as far as I'm aware, minutes and everything else is published and available. I just would love, I'd like to stress that at all times, I always felt I was working in an organisation that was being transparent. That's the point that I was there, and I was never ever told not to be that. Whether the communication is effective between the two is for those who derive those media statements to answer.
Now, Mr. Duncan, you were going to go on to another matter, which I'm quite content that you do. If you want to do that.
Perhaps we might as well just take the break at this point, my lord, and we can move on to the next stage after the break, if that suits your lordship.
Very well. We'll take 20 minutes for a coffee break, and we'll sit again at 5 to 12.
Okay.
You could.
Please stand.
Before I ask the witness to join us again, can I remind legal representatives that conversation may be appropriate when the witness is not giving evidence, but conversation is not appropriate when a witness is in the course of their evidence. I'm sure legal representatives appreciate that.
Aye.
Mr. Duncan.
Thank you, my lord. Mr. Redfern, I was going to move on and ask you about a couple of other IMTs from still in June 2018. And the first one I'd like to go to, please, is in bundle 1 at page 119. And it's not really something that is arguably anything to do with this hearing. It's just to see if you can help me a bit with a detail that may be of importance in some of our other investigations. So again, we see it's an IMT that you're at on the 12th of June on the face of it. And if I could just ask you to go, please, to page 121. And if we enlarge the section under staff, and if you just read to yourself that section about NHS Lothian, so those 5 paragraphs, and then tell me when you've done that.
Yep,
Thank you.
I've read it.
Now, again, I emphasise, I'm only really trying to find out where we go to investigate this, if it is indeed something that needs to be investigated. Do you have a recollection of what that was about?
I do.
Can you maybe help us?
So there's 2 points to this. The first is, I think, a question you alluded to earlier about learning points and about new builds. And I think that's the reference to whether or not there would be communication between the respective boards at medical director or chief exec level or whatever level of the organisation around what Glasgow is experiencing to what might be relevant to Edinburgh. I think that's what that component is. The latter bit is around the fact that if we have got issues operationally within Glasgow, there needs to be a discussion with my counterpart in NHS Lothian about their ability to take patients.
Thank you.
So one is an operational issue and one is a more strategic build issue.
Thank you very much. Okay, if we move on, please, and if we could go, please, to the next IMT at page 128 in the bundle. It's an IMT of the 15th of June. Again, see that you are present. Now, the evidence we've had at this stage is that, again, there are a number of cases of gram-negative bacteria. There's also a case of a gram-positive bacteria that we might speak about later. So I won't take your time up on that just now. If we go, please, to just page 130. And it's underneath the heading of communications. If we just enlarge the paragraph that has Jamie informed. Thank you. And again, Mr. Redfern, if you could just take a moment to read that and indicate once you've done it.
Yes.
Thank you. Now, can you, well, two things. Do you have a, first thing is, do you have a recollection of a discussion along those lines at this time?
Yes, I think I do.
And are you able to explain to us what this indicates?
So I think it's to do with the two IMTs that were built in around this, one about the water supply in particular, and then the second about the implications of the drains and about just how we were communicating that.
Yeah, and are we to take from this that you're feeding back that there's some confusion on the part of parents?
Yeah, that's what it says.
And would you indicate then whether that suggests that, at least from the perception of parents, communication was not all it could have been?
I think that if there's confusion with parents, then yeah, I think you can take that.
One of the things that we can put that to one side, Mr. Castell. One of the things that's already been looked at with another witness is the information, written information, that was being given to patients at this time regarding the use of hydrogen peroxide vapour. And the fact that all it said was that it was happening and that there would be a need to decant rooms, but with no explanation for why it was necessary. Now, does that accord with your recollection of what was being provided?
It certainly wouldn't have been the information that I was given to, that I would have been given to our clinical teams and or explanation I would expect to be handed to parents.
Okay, well, I mean, maybe best just look at the document then. Can we go to bundle 5, please? And it's page 144. Now, again, could you just take a moment to read that, please? And tell me once you've done that.
Yes.
Thank you. Now, it's the inquiry's understanding, it's only an understanding from what we've been told by the Health Board, that this was a written communication that was provided to patients around about the time that we've just been speaking about. Does it look like that to you?
Yeah, it's an explanation of what HPV is and why we're doing it. Well, why we're doing it in terms of the outcome of what HPV will provide.
Yeah, I think you've just touched on the issue. In fact, I don't think it does say why it's being done. Is that right?
Yeah, it doesn't give a reason specifically of what has triggered the HPV.
Yeah. Why would that be?
I don't know what. I think the statement is obviously being prepared to explain what is happening and the impact it will have on the child and family.
If we proceed on the basis of our understanding that this was a written communication that was to be used to update patients and families, how would that written communication have come about?
My understanding was that would have, if this was a solution that had been proposed through the IMT process, then it will have been an action set from that meeting.
Yeah. So the understanding is that what I take from your answer is, and the document is, that the settled position of the IMT was that patients and families were to be told that HPV cleaning was happening. Yeah.
Yes.
But it doesn't indicate that they've to be told why it was happening. Is that right?
From reading the document, it doesn't.
Yeah. But why would you not want to tell patients and families what the concern was that the cleaning was intended to address?
I don't know why the statement doesn't have that, and I never prepared the statement. What I would say again is that in discussion with the clinical teams and with any parents, when we were walking about the ward, we would have explained that it was all part of the IMT process and that it's an effective mechanism for ensuring a clean environment in the hospital.
So, sorry, say that again?
It's an effective mechanism.
No, all of what you just said.
Oh. So my understanding would be that as part of what I've described earlier in feedback from the IMT, both to clinicians and to parents, if speaking to them or asked, that it was a recommendation that came from the IMT, and it's a belt and braces approach to ensuring a clean environment.
Yeah.
It's a well recognised process that we chose to implement.
The patients and families who've been on the ward, whether it's inpatients or outpatients, have been through the situation in March. Is that right?
Yes.
We know that there has been a return of infection concern in June. Yeah?
Yes.
And the settled position of the IMT is to tell them that there's going to be cleaning, but on the face of it, not to tell them why that is so. Is that right?
I don't know whether it would have been it wouldn't have been the instruction of the IMT not to tell them. That would not have been an instruction of the IMT.
So there wasn't an instruction not to tell them, but nor was there an instruction to tell them. Is that right?
I think my recollection of any IMT would, as I've said before, is that it would be as informed as we possibly could be, and that we had a return of infections and that we were going through a whole range of solutions to how we would try and resolve the situation.
Yeah, I'm not sure that's an answer to the question, Mr. Redfern.
Sorry.
On the face of it, if this is setting out the settled position of the IMT, which I take you to be saying it is, on the face of it, there is no instruction to tell patients and families why cleaning is taking place. Is that right?
It doesn't say there why.
Yeah. Now, again, just putting yourself in the position of patients and families, can you say whether you would find it understandable that they might think they're not being told the whole story?
Yes, I could see that position.
Thank you. Now, if we move on, please, I want to go, we can put that to one side, please. We go on to July. And again, we've had some evidence about the cases in July, and I won't trouble you with that. One thing I do want to ask you about is this. Thinking about what we've just been looking at, the IMTs in March 2018 and in June 2018, and moving on into July, can you say whether you were aware at that time of the discovery of a risk assessment of the water system that had been carried out by a company called DMA Canyon 3 years before?
No.
Do you recall any mention of that at that time?
I can't remember.
Have you subsequently heard about that?
Yes.
Are you able to say when and how you found
I've just seen it in a variety of media and
a variety of
different stories around the public inquiry and reference to it.
Okay, so are you saying
I haven't formally been said, here is a document, please read this, if that's what you mean.
no? What I'm asking you is, when did you find out about its existence?
I can't remember the specific time of it. I honestly.
What you indicated a moment ago, Mr. Redfern, was that I took you to associate it with media attention around the public inquiry. Is that right?
Yeah, I think so.
Are you saying, therefore, that you don't recall it ever being brought to your attention by any source within the health board?
I can't formally recall ever being told that about that document.
I mean, you held at that time, even at that time, a pretty high, a pretty senior managerial position. If there were a document, a risk assessment that had been discovered in 2018, but a risk assessment that dated from 3 years before that, and if it were the position that the risk assessment raised concerns that had not been acted upon in the interim period, thinking about your role and your responsibilities, is that the sort of thing that you would have expected to be drawn to your attention?
Yes.
And are you saying it wasn't?
Not that I'm aware of.
So if we think about the events in the run-up to the decant, are you saying, I mean, let me take a step back. You've obviously indicated that you are aware of this issue as being something that's of interest to the public inquiry and the media, is that right?
Yes.
Have you given any thought prior to today about when it was that you yourself learned about the existence of this report?
I suppose more that my primary focus in all of this has been how I manage the situation operationally on the ground for the circumstances that we faced. That was where my primary focus was on. I do have, obviously, an understanding that anything I was communicating through the different stages of how we were doing that with patients and families that was accurate and was transparent.
I have your position on that, but that's not the question I asked. I asked you whether you've given any thought prior to this moment as to when you became aware of the existence of this report.
Yeah, I would have liked to have known it quicker than what I did.
But have you yourself cast your mind back or carried out any investigation or spoken to anyone about this?
No.
Are you coming along here as the director of the Women and Children's Directorate to say that you have no idea when the risk assessment carried out by DMA Canyon was brought to your attention?
Yes.
And are you coming along here to say that you've had no discussion or carried out no investigation on that point?
I've not carried out any formal investigation on that.
Okay, thank you. Now we can move on to another issue that arises around about that time. And it's an issue to do with cladding, and you deal with it in your statement. Now, I'd quite like to take this reasonably quickly if we can. In your statement in relation to the issue of cladding, I think you explained it was to do with a concern that arose out of the Grenfell inquiry. Is that right?
Yes.
Yeah. And I think what you say in your statement is that your role was to ensure that we understood how we would maintain as near as possible business as usual. Is that right?
Yes.
Now, can you explain what it is that you required to do to achieve that?
So it was primarily about inconvenience to patients as the work was completed, or patients and families in particular noise.
Okay. But just trying to understand what you say, are you indicating that there having been an issue identified in relation to cladding that required action to be taken, your job was to ensure that that was addressed in a way that did not impact upon patients and families?
Yes.
Yeah.
And obviously also that we had strong communication on what was happening, and that we had robust protection in terms of any implications of the work that was going on, working with infection control.
And if we think about what we've been discussing thus far about issues to do with the water system, is it also your role to ensure that that was responded to and addressed in a way that maintained as near as possible business as usual.
That's my role. That is what I saw my role as, operationally, trying to deliver a service with the circumstances that we faced.
Now, just on the issue of cladding, you've got some evidence in your statement about this, about communications to patients and families in relation to this issue. Can you confirm whether or not, as far as you recall, there was or was not something of a delay in relation to that happening?
I think there was. I think that was articulated in a minute that was shown to me when I was preparing my statement, that I had said that. I can't specifically recall it now, but it's written there.
Okay, thank you. That's helpful. Now, we have quite a number of email communications on this, and I really don't want to take time up on this if we can avoid it. So if I put some propositions to you, can you say whether you agree with them? And if you don't, we can always look at the documentation.
Yes.
The understanding that the inquiry team has is that a concern about an impact from the cladding works was raised sometime in about mid-August of 2018. Would that be about right?
Yes.
And that there was a request at that time, mid-August, for a communication to go to patients and families to explain what was happening and the contingency around that. Would that be right?
Yes.
And the emails that we've seen indicate there was a delay waiting for sign-off at senior level. Can you recall that?
Yeah, I've seen the email.
Yeah. And in fact, there was a chasing email from you now into the beginning of September to Mr. Hill to get a position on what patients and families were to be told. Is that right?
Yes.
And the briefing, I think, was eventually issued round about the 7th of September. Does that accord with your recollection?
Yes, but from what I've read from the email correspondence.
Can I ask you two questions, and you deal with them in whatever order you wish? First of all, what was the process for getting sign-off on this communication? And secondly, why did it take so long?
So the process was a standard that we would identify a need for communication with families from the intelligence we were picking up at the ground level, and that it would be prepared through the organisation's comms department. The delay, and I can't, I don't know why there was a particular delay in that. It was just that it was an outstanding action that I wanted followed up on.
Yeah, I mean, as you've already indicated, the process of communication seems to have involved senior level. Is that right? Any
media statement comes through corporate comms. We would not do them ourselves.
I'm talking about senior levels of management. I mean, do you have any understanding of the levels of management at which this communication was being handled?
Certainly, Chief Operating Officer, if not above.
Yeah, thank you. Now, if we can move on then to a different topic, and just trying to move forward through the chronology to September 2018, I'm going to ask you a bit about the decant from wards 2A and 2B. And I think probably the easiest way to do this is maybe just to take, it might help you a bit in terms of focusing your answers. I'm going to take it in two bits. The first thing I want to really explore is the reasons for the decant and the communication around that. And the second thing I'm going to look at is the analysis around where the patients should go. We know they ultimately went to 4B and 6A, and I'll ask you about the work that you did on that a wee bit later. So if we start then with the reasons for the decant and the communication around that, you say in your statement, I think, that it was to implement a change in the sinks, is that right?
Yes, as I've alluded to earlier.
I just wonder if there was any more to it than that, as you recall.
The reason for the decant, that we were working on the basis of an IMT instruction that the solution to eradicate the risk, or to take away the risk of infection following the proximity of tap to sink was to remove those sinks, and to be able to remove those sinks, we had to find an alternative location. We couldn't, if we had continued trying to do the removal of sinks, then we ran the risk of children being infected.
Yeah, thank you. I think you have essentially answered the next question I was going to put to you, but I'll tell you what the clinicians said about this last week. They said that looking at the IMTs, their recollection is that they were around from March into September, they were around 23 gram-negative bacteremias by that stage, a hypothesis of an environmental cause, a concern from Professor Gibson at least about a site-wide problem, a reference to the staff not feeling the unit was safe, Dr. Murphy saying that he was concerned that there would be further problems and indeed that the rest of the site would be a risk. And one thing that was said was that there was unanimity among the clinicians that they wanted off the unit. Now, can you recall whether that accords with your recollection of things?
In answer to your question, yes. However, I think the context within that is that there were two separate scenarios that we've described in terms of the IMT process and that number of infections. In terms of the first IMT, which is the replacement, the filters being added to the taps, we thought that was eradicating the problem, and that the solution followed up with the treating of the water would have resolved the situation, and we would have had a safe clinical environment in 2A, 2B. The unintended consequences of that prompted the second run of infections, which we had no similar solution to put in place without moving, and therefore, as part of the ongoing discussion with the clinical team, it was felt necessary to move.
Yeah, I mean, at the risk of repetition, I mean, I think as you said yourself, or I took you to say earlier, there was a continuing concern about a risk of infection is point one, and point two is the work required to address that required the children to be removed from the ward. Is that right?
Yes. Without doing that, we had no solution similar to what we had at the time, or thought we had at the time, with the filters.
Okay. Now, what I would like to do now, Mr. Redfern, then, is to just look a bit at the IMT minutes that deal with the decant. And as I indicated, one of the things I'm interested in at this point is the communication on this with patients and families. And we'll come to the choice of decant destination in a minute. So, Mr. Castell, could we go to bundle 1, please, and look at page 160? Now, when you orientate yourself on this one, you will see your name is not there. I don't think it is anyway. So I don't think this is one that you recorded as attending, but you were at the next one. And I think you said earlier that the minutes of previous ones would be before the next one. So that being so, is it likely that you'll have seen the minute of this meeting?
Yes.
Thank you. Now, if we just look at, if we stay please on page 160 and maybe just enlarge the section at the bottom under incident update. And if I tell you that the redaction is to do with patient confidentiality and that we've taken a better safe than sorry approach as regards that. So I will just tell you that obscured by the redaction is an indication that there were a certain number of gram-negative bacteremias being focused upon at that time. If what I want you to look at, however, is if you go over the page 161, and if we enlarge the top paragraph, now, accepting that you weren't there when this said this, but I'm just wondering if you can help us with it. It seems to record Dr. Inkster saying something, typing results some patients remain outstanding. Teresa said she is not able to classify the cases in more detail. Teresa explained that typing results in an environmental incident are unreliable. And have you got a recollection of that sort of thing being said around that time? By Teresa Inkster, I mean.
And through the IMT process, there would obviously always be investigation of through microbiology about typing of patients. And sometimes there were delays in that typing, sometimes there was contamination, sometimes there were a whole variety of things that would influence how the IMT would react in the fullness of time and accurate information being available. I think that is just an example of where we were waiting for further information. She would need to explain the processes and everything that was involved in that.
I mean, a recurrent theme in your evidence and others is making sure that people aren't being asked to give evidence on things that they're not expert in. So I understand that you're not a microbiologist, but there's a record on the face of it of Dr. Inkster saying that typing results are unreliable. And I'm really asking you a whether you remember that ever being said at that time.
I can't remember that specific line because I wasn't at the meeting and I can't remember it being picked up at the future meetings. I'm clear in my mind about that we had a problem and that we had to seek an operational solution to resolve it. So I don't think we ever disputed that there was an issue in that.
If I was to suggest to you that what it might indicate is that Dr. Inkster is saying that she herself doesn't consider that typing results are reliable in environmental incidents, is that something that you can offer a view on?
No.
No. Okay, fair enough. If we go over the page, please, to page 162. And I want to focus on the section that's redacted. Now, again, our redaction has been very much better safe than sorry, and I'll help you with a bit of what's underneath it, which is that Dr. Inkster appears to be indicating that certain patients, parents affected by gram-negative bacteria should be spoken to. And I mention that, Mr. Redfern, just so that we can understand the bit that's not redacted, where she says, Teresa explained under duty of candour that they should be spoken to as well. So there seems to be a discussion about a communication that has to take place in the context of duty of candour. And we can see from the IMTs that I think it's in 2018 that we do start to see duty of candour as being something that's flagged. And I'm just wondering if you're able to help us understand what that is and why it starts to appear at this time.
I would go back to my original comments that any child or family who were part of an IMT should be fully informed of that. Whether there was a reason why we started to use the word duty of candour, which to all intents and purposes what it is that we're being very articulate in terms of what circumstances a child and family are facing, that was carried out and that it should be reported through the IMT process, that it was done and is documented.
Okay. And I'll help you a bit with this. I'm not trying to put you in the spot and tell us all about the legislation on organisational duty of candour, but I think the statutory provisions on organisational duty of candour came in April 2018, and maybe that's why we start to see it being mentioned. Yes. Yeah. How would you understand the organisation's duty of candour? How would you describe it?
I would say again that those directly involved in the with a child or family who have had an infection should be fully made aware of that circumstance, and what the likelihood of cause was, what was happening with them, and how we were hopefully reaching a successful outcome for the child and family. In terms of the wider organisational responsibility, it comes to the whole commentary that we've been discussing, that those associated with similar children and families were aware of the risk and were aware of what was happening.
Yeah, thank you. And that's very helpful. I mean, my understanding from my own research as regards to the legislation is that duty of candour, organisational duty of candour, I mean, is about a duty to be candid about unintended or unexpected incidents which result in or could result in harm or additional treatment. Would that accord?
That's what I meant.
Yeah, yeah. And I understood you to say in your answer there that you would see that as being engaged at a point where there has been an infection and the parent would need to be told about the infection.
For individual parents, yes, and I would have assumed that was happening and would expect that to happen prior to the legislation.
Yeah. And that, I think you said one of the things that the parent would, or the patient would require to be told would be the likelihood of the cause, is that right?
Yes.
Yeah. So are you saying that at the point where there's a hypothesis that's accepted by the IMT, that would, as you see it, engage the requirement to tell the patient and the family about that hypothesis?
Yes.
What did you say there?
100%.
100%.
That would be my view.
Yeah. So a hypothesis would engage it. Yeah.
Yeah.
Okay. Now, if we move on, please, I want to go back then to just try and understand the timeline on the decant communication, if we can. So if we go, please, to still in bundle 1 to page 164. We've got an IMT of the 14th of September 2018. You're attending it. One detail I'd quite like to pick up on, which I think might tie in with what you were saying earlier about the hypothesis. And if we go, please, to page 165, under control measures continued. Can you just have a look at the paragraph with the reference to aerosolization and tell me when you've done that?
I've read it.
Yeah, is that what you were describing earlier about the interaction between the filters and the sink, or is that something different?
No, I think that's something different.
Do you know what that is? Can you recall?
No, I can't recall that particular commentary from Ms. Rankin.
Okay, thank you very much. Could we go over, please, to page 166? And if we enlarge the phase 1 contingency continued. Dr. Kennedy questioned that due to this problem potentially being throughout the whole hospital, then management must liaise with CDU with regards to having a room that has had their drains environment cleaned for patients being admitted into Ward 2A via CDU. Do you have a recollection of that sort of thing being said?
That's a patient pathway for hemato-oncology patients, and it would stand to reason that while they were in CDU, they were in as safe an environment as they would be in 2A, 2B, or moving from CDU to wherever we decanted.
I'm asking you whether you recall an indication or a discussion around the problem potentially being throughout the whole hospital.
So there would be the same sinks right across the hospital. We would have the same issues with the water supply, hence why we were looking to the replacement of sinks. And as a result of that, we had nowhere to decant within RHC. So yes.
Are you saying the whole hospital refers only to the children's hospital?
Yes, because there were different types of sinks in the Queen Elizabeth, which is my understanding, hence why we were allowed to move there.
Okay, thank you. So if we go on, please, to page 167. And I want to look at the communications section again, if we could maybe just enlarge that. And we see that there's a redaction section which doesn't particularly matter. Communications have been sent out with regards to increased drain cleaning. There will be more communications to patients once a decision has been made by the senior management team this afternoon. And then under the heading public, the media will be contacted once the senior management has met after this meeting to agree if they go with the proposals of this IMT. You see all of that?
Yes.
Does that indicate that as far as the process of communicating with the patients and families are concerned about the decant, that's a decision that's to be made by the senior management team? Is that right?
Yes, that's what it says.
Yeah. And the media will be contacted once the senior management team has made its decision. Is that right?
Yes.
And is that the decision around the decant?
Yes, I think that's what that refers to.
Yeah, thank you. So if we move a little forward in time to page 169, we see the IMT of the 17th of September, page 169. Again, you're present. You see that?
Yes.
And just to pick up on a couple of points in the IMT itself, as we've got it in front of us. If we go to page 171, please. And we enlarge the second paragraph. Have you got if you just take a moment to read that first sentence. You done that?
Yes.
Have you got a recollection of Dr. Inkster relaying expert opinion that you should not be having to clean the drains continuously?
I recall the name Peter Hoffman. I recall there be discussion between Dr. Inkster, him, and a number of other UK or international experts in the issues that we faced, in the particular line about what came thereafter from Mr. Hoffman. I can't specifically remember.
Thank you. If we go over the page to page 172, and underneath contingency/decant, Mr. Hill assuring the group that decant option was not off the table. It's really the last sentence I'm interested in. It was stressed that a decant should be as short as possible and may take up to 4 weeks. See that?
Yes.
And can you recall whether that is what was being said at the time?
I can't recall the specifics of 4 weeks, but I do know that we would want a decant to be as short as possible because of the operational challenges that it would present, but it would have to be moving back into a safe environment, so it would be as long as it had to be. If that was an estimation at the time of 4 weeks, I can't remember that that particular time being put forward, but it's minuted, so obviously that was what was thought of at the time. I would have assumed, from my recollection, I was assuming more of an 8 to 10 week period.
Okay. And a little further down the page, again, it's just to maybe help us with a detail if you can. You might not be able to. The paragraph that starts Mary Ann Kane, where it says, Mary Ann Kane wanted to emphasise, have you got that?
Yes.
Wanted to emphasise that the facility that the children would be moved to on the adult QEUH site was not better from a ventilation perspective. Can you recall that being said, or what that was about?
So we were moving to the Queen Elizabeth. We were not moving to a specific hemato-oncology unit. So we would have the infrastructure that a general ward in an adult environment would have. I think that's what she ultimately means. Obviously, there is an exception to that in moving to 4B, which was for the bone marrow transplant patients, which did have the infrastructure for a transplant unit, because that's where the adult transplant.
The ventilation
services.
infrastructure.
Yeah.
Yeah, thank you.
So we were in a general adult ward,
Yeah, thank
not
you.
a purposeful built paediatric hemato-oncology ward.
Now, if we go over the page, please, to page 173, we get to really what it was I was particularly wanting to ask you about. So if we enlarge the top half of the page, thank you. And it says, it was agreed that the statement created on Friday, but not shared with patients, but not shared with parents, can be updated. Now, if I just stop there and help you, Friday was the 14th, so the IMT that we just looked at was the Friday. It should mention that there was enhanced cleaning undertaken over the weekend and ongoing maintenance of drain cleaning. And just, if we just pause there, are we to understand that at this point there hadn't been anything issued to patients and families yet?
I think that's what that's saying.
Yeah. And if we go down the page, please, to under the heading of public. That's fine. Claire Cook from the press office said that no proactive statement was released regarding the possibility of decanting. And there's a reference to a draft statement at the weekend stated that enhanced cleaning was being undertaken in Ward 2A and 2B. You see that?
Yes.
Now, if we just go back up, just to pick up a detail, please. Back up to the section under staff, and if you could take a moment to look at that and just tell me once you've done it.
Yes.
Can you recall?
I can recall that,
Yeah.
that particular event.
It might be thought to indicate a fairly high level of anxiety among staff. Would that be fair?
Yes.
Is that how you recall matters at the time?
Yes.
Yeah. Now, if we go on a little further in time, and we'll turn up the documents if we need to, it's our understanding, the inquiry team's understanding from the documents, that just going back then to the communications bit of this that we've just looked at, and the bit about not telling the patients and families just yet, it would appear that there was a media briefing on the decant that day on the 17th of September 2018. Is that something that you have a recollection of?
I can't have specific recollection of having a media briefing and having a draft staff briefing. What I would expect at the time would have been that we would have had a formal communication to both groups, to the media and to parents and families and to staff of the decision being taken by the IMT, reinforced by the corporate management team, and how we would be undertaking that and what it meant for families.
Yeah. I think we know from, or at least the evidence indicates from Jennifer Rogers' statement, that it wasn't in fact until the IMT the following day on the 18th of September that a communication to parents was approved. Does that accord with your recollection?
Yeah,
Yeah. So if we accept, and I think you're accepting that there had been a communication to the media on the 17th, but the one to the parents didn't go until the 18th, it's obvious that there's been a disconnect there, is that right?
There's been a difference in the timelines.
Yeah. I mean, we had quite a bit of evidence from the patients and families about this, that some of them had learned of the decant from the media. Does that
I
chime with your
remember
recollection?
parents indicating that.
Yeah. And can you remember how they felt about that?
Not good. I'd much rather have had a proactive approach, being able to deal face to face with any parent or family around the circumstances being faced.
One of the things we heard quite a bit of evidence about last week was about the process for patients who are on a path towards a bone marrow transplant and how time critical that can be, both as regards getting the treatment and as regards ensuring that the donor is available. And I'm just wondering whether, thinking about that sort of patient, whether it's easy to understand just how stressful it could be to learn from the media that you might be about to move from your current ward.
I think it would be stressful for all patients in my own oncology family.
Yeah. Now, just to complete this bit, and we'll move on to the decant options in a minute, I want to go to one last IMT from this stage, please, and it's the next one. It's page 175 of Bundle 1. And it's really, again, just to pick up on a couple of details. I think we see again, Mr. Redfern, that this is one that you were at. Is that right?
Yes.
And if we go over the page, it's again just to try and see if you recall something being said. We enlarge the top paragraph. Just take a moment to read it, please, and tell me when you've done that.
I've read it.
Thanks. Have you got a recollection of a discussion about a concern about the temperature of the water within the water
I
system?
don't have a specific recollection of that, but if it's minuted, then it would have been discussed.
Thank you. And if we go over the page, please. Page 177, and if we go to the foot of the page, Mr. Castell, the bottom paragraph, if we just enlarge that. The group has agreed that an area within the RHC site would not be suitable for a decant. Can you recall that?
Yes, I've alluded to that already by the fact that the proximity issue, which to my recollection and understanding was the issue, which was prompt and splashing. It was the same type of sinks that were in there, and we couldn't resolve the issue by moving to another ward in the paediatric hospital. That was not the case in the QEUH.
Okay, thank you. And finally, just if you can help me with one aspect in relation to communications. Over the page at 178, under communications, and if you want to read all three paragraphs, do so, but I'm really interested in the third paragraph. It was agreed a statement for staff, parents, patients and the press will be drawn up out with this group. Each communication should have the same common narrative with strict disciplines. Why was the communication being drawn up out with the group?
I think from recollection of that, that would be individuals within the group that were doing that, and it's maybe just been how it's been worded in the minute.
Okay, thank you. We can put that to one side. Now, I want to hopefully get through this before lunch. I want to start moving on then to the decant options. Yes. And maybe let's take it in these stages. First of all, what was your role as far as identifying a decant, an alternative place for the patients to go? So
operationally, I had, through the IMT process, been told that we had, as a solution, we had to move out with the ward. My role would be to facilitate that.
Yeah. Is it back to the ensuring how you were going to maintain as near as possible the same service?
Yeah. So I had two primary objectives in terms of maintaining service: the general hemato-oncology inpatient day case service and the bone marrow transplant national service for Scotland.
Okay. Now, I would like to ask you just some questions about, we can see from the IMTs that a number of possibilities were considered.
Yes.
And one I would like to ask you a wee bit about is the use of a new modular unit, which ultimately was not selected as the preferred option. Why was that?
The primary reason from memory was the timeline that it would take for a modular build, the estimated timeline for a modular build to be procured and situated and fit for purpose, and also whether or not it was actually a practical solution that we could implement, bearing location and pathway between said location where we put the modular build and how we would actually create a safe environment for patients moving backwards and forwards from it to the rest of the hospital.
Okay. So just so I've got that, it was the time scale is one.
Yes.
And the pathways is the other.
Yeah.
Okay. Could I have you look at your statement, please, Mr. Redfern? It's at it's in the statement bundle at page 390. And I think you set out paragraph 88.
Yes.
Certain criteria.
Yes.
And were these the criteria that you had regard to when you prepared your decant options paper?
Working with the clinical team, that was what we came up with. The key criteria that would decide what the final option we choose would be, yes.
And if we look at paragraph 89 now, you explain why the Beatson wasn't used. And then,
sorry.
And then you say, due to point 4, a new modular build was not possible. You see that?
Yes.
And is that a reference to D, an ability to scale up at the earliest opportunity?
Yeah, sorry, it says D instead of point 4. I think that's a typo.
And what's the ability to scale up at the earliest opportunity?
Have it in place.
Have it in place.
Yes.
Right. It doesn't indicate anything in relation to having to scale up in the event of some change in the patient cohort or anything like that?
No, I don't think so.
No.
It was primarily with the commissioning of the building, but it was also, as I say, about the pathway from an external environment internal to the points made in 88.A.
Yeah. So, that's helpful. We're to understand that the ability to scale up at the earliest opportunity refers to the time within which...
I think so, yeah, that was certainly clear in my mind what it was.
Okay, that's helpful. Thank you. Now, one of the things that you say in your statement also about the decant, one of the considerations around safety was the fact that the source of water in the adult hospital was the same as in the children's hospital. Is that right?
Yes.
Just single supply. Is that right?
Yes.
Now, a number of witnesses, patients, parents, and clinicians appear to recall having been told that it was a different supply in the adult hospital. They don't, I think, say that you said that, to be clear, but they have a recollection of understanding that. Do you have any explanation for that?
No, and certainly my position around all of this was it was the same water supply. The only different water supply was to the, from recollection, was to the maternity hospital on the campus.
Yeah, thank you. Now, just a couple of other points of detail about Ward 6, Ward 6A and Ward 4B. And if you don't know the answer to this, please say, were there point of use filters, if that's the word, on the showers as well as the taps?
I don't specifically know, but what I do know that is what the instruction of Dr. Inkster would have been prior to the move. They would have been fitted.
Thank you. Please do not think that I'm suggesting that they weren't there. I genuinely don't know. I just, something that had occurred to me. Are you indicating that, well, actually, let me not lead you on this. What are you indicating?
So what I'm indicating is that prior to the move, Ward 6A, as we've described, was not, wasn't a hemato-oncology, paediatric hemato-oncology unit. So there was a lot of preparation work which was carried out prior to decanting to that ward, and instruction would have been from microbiology, infection prevention control and the clinical team around what they would expect. And there was a process put in place to make sure that prior to the move, operationally, every action against that was completed.
Okay, thank you.
And I would assume that would include the use of filters to the satisfaction of Dr. Inkster.
Yeah. Can you recall whether there was a risk assessment made in relation to the move to 6A and 4B?
Yeah, there was a whole process put in place around risk assessment and around standard operating procedure for overseeing that move.
I'm thinking in particular about risk assessment in relation to any repeat of the sort of risks that had been perceived in the children's hospital. In other words, risks from the water supply. Was there any risk assessment around that you recall?
I can't remember a formal risk solution, but I'll give you the context of what my understanding was at that time, that Ward 6A would be equipped with the filters, that the treating of the water supply had been carried out, it had been found effective. The deficiency in the children's hospital was the splashing from sink to filter, and that was not an issue for Ward 6A or for Ward 4B.
Okay, maybe if I rephrase my question, which department or which area of management should the inquiry look to find any risk assessments that were made in relation to the move? Whose responsibility would that have been?
I think that would have been a shared responsibility between the Directorate, Infection Prevention Control / Microbiology and Estates.
Okay, thank you. And the final question on this is, can you recall what, if any, contingency planning was made at this stage around what would happen in the event that there were further problems on Ward 6A and 4B?
I can't recall further contingency of a further move, because I don't think there were other options open to us at that time. However, we had confidence in the situation that the filters were functioning the way they should function, and that the risk of splashing was resolved, and therefore we were of the assumption that we were moving into an environment that was, while not ideal for the reasons I've just described, was functional.
Thank you, Mr. Redfern. My lord, I have come to the end of a chapter, so this may be a suitable point.
I can only congratulate you on your timing, Mr. Duncan, because that seems pretty well dead on 1 o'clock. We'll take an hour for lunch, Mr. Redfern, and you'll be taken to the witness rooms. We'll sit again at 2 o'clock.
Please stand.